Hello, everybody, and welcome to the IOCDF Research Roundtable, the IOCDF live stream, where we pick an interesting topic within the field of OCD research and discuss it with the folks that know it best. My name is Kyle King. I am your host of today's show. I'm a first-year medical student at Yale University School of Medicine, interested in all things brains, but particularly OCD. Not only because I think it's a really interesting disorder, but also because I have it. So a lot of the discoveries and breakthroughs in the field of OCD research pertain to my life very directly. And as always, I'm joined by my co-host, Jonathan Abramowitz. John, if you'd like to introduce yourself.
Hey, thanks, Kyle. I'm Jonathan Abramowitz. I'm a professor at the University of North Carolina at Chapel Hill. I'm also fascinated by all things OCD. I don't have it, but I've dedicated my career to learning as much as I can about it and helping folks who have it and training folks to do what I do. So I am very excited as always, for today's roundtable.
Yeah, no, I'm super pumped for our roundtable. We have three lovely guests who I'll get to introducing in a minute. Today, we're going to be discussing surgical interventions in OCD, which is something that I've become increasingly interested in ever since starting medical school. And I think been trained to think about things a lot more biologically than I previously had. And we have an all-star panel today. So I'm definitely going to get to learn a lot. Before I get to introducing our panelists, though, I do have a number of announcements that I have to make. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you are ever in a crisis or if you're feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org or go to your local emergency room or call 911. Just a quick announcement about research. You can still have time to donate to the IOCDF to support research grants. The Innovator Awards are still open, and you can apply to that by Friday, March 21st. So they're still open, but not for too much longer. And there's a grant for senior OCD researchers only. Just to put that out there. And the final announcement, this is a live stream. There is a comment section. We love when you put your questions in the chat. We'll try to get to as many questions as we can. Just know that anything you put in the chat will live on the internet forever. So please be respectful, although we've never had any particular issues. Okay, I think that's enough of my voice, at least on the announcement side. Time to start introducing our panelists. I'll start with the first bio that I have here on my sheet, and that's Dr. Nicole Provenza. Dr. Nicole Provenza is an assistant professor of neurosurgery and a McNair Scholar at Baylor College of Medicine. Dr. Provenza holds adjunct appointments in electrical and computer engineering and bioengineering at Rice University. She received her PhD in biomedical engineering from Brown University and completed her postdoctoral fellowship at Baylor College of Medicine. Dr. Provenza's laboratory studies the neurophysiology underlying cognition and emotion and the effects of neuromodulation on neural activity and behavior. Dr. Provenza, I was given the go-ahead by Boris backstage to ask a silly question as an opener. So, if you could switch lives with one cartoon character for a day, which one would it be?
Probably Tigger from Winnie the Pooh.
Wow, that was an immediate answer. I respect that. Okay, well, thank you for knowing right off the top of your head. And Wayne and Ali, the same question's coming to you in a second, so get ready. Our second panelist today on my sheet here is Dr. Wayne Goodman. Wayne Goodman, MD, and Irene Elwood, professor and chair of the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine, specializes in OCD and deep brain stimulation for intractable psychiatric illnesses, so definitely a good person to have on today. He also conducts research on non-invasive forms of neuromodulation, including low-intensity focused ultrasound. He's the principal developer of the Yale-Brown Obsessive-Compulsive Scale, or the Y-Box, the gold standard for assessing OCD, and the co-founder of the IOCDF, which you may or may not have heard of. He was elected a member of the Association of American Physicians, Distinguished Life Fellow of the APA, and Fellow of the ACNP. Dr. Goodman has published over 400 peer-reviewed articles and is recipient of grant funding as a PI from the NIH Brain Initiative for DBS in psychiatric disorders. Dr. Goodman, thanks for being on. The same question goes out to you, though. Switch.
Popeye. I like spinach and I like big muscles.
There you go.
Okay. Again, I like that it's like everyone's thought about this before. Like this was a conversation at the dinner table like last night. All right, our final guest is Dr. Ali Tafreshi. Dr. Ali is a neurosurgery resident at Geisinger Health System in Pennsylvania and is working as a research fellow in the brain modulation lab at Harvard Medical School and the neurosurgery department of Massachusetts General Hospital. His current project, funded by a grant from the IOCDF, examines neurophysiological patterns in sensing-enabled neuromodulation in patients undergoing deep brain stimulation surgery for OCD. He plans to complete a postgraduate fellowship in functional and stereotactic neurosurgery and continues to work on innovative approaches to treat patients with neuropsychiatric diseases. His long-term goals include optimizing treatment for, increasing utilization of, and improving access to neuromodulatory and other surgical treatments for neuropsychiatric diseases. Dr. Tafreshi, thanks for being with us. Your cartoon character.
Thanks for having me. I think mine would probably be Winnie the Pooh himself, actually.
Interesting.
I like his lifestyle, yes.
Interesting that you like his lifestyle and yet you're a neurosurgical resident.
There you go.
And it's also good to know that you and Nicole are both on the stream because you're clearly compatible. And then I guess Dr. Goodman, you'll kind of be the brawn of the operation today. So today, like I said, we're going to be talking about surgical interventions. We talked about DBS a lot in the bios there. But before we talk, a lot more specifically about DBS, I kind of want to just get a general overview, and I'm going to pitch this to Dr. Goodman. What are kind of the surgical interventions for OCD just broadly that are around today?
Well, the one that we're going to focus on is DBS or deep brain stimulation, and I'll probably pass it soon to Dr. Tafreshi because he's the neurosurgeon. But I have had a lot of experience working with neurosurgeons over the last 20 years, and the other form of surgical intervention that is sometimes used in OCD is called ablative or lesion therapy, in which there's actually a very small, precise lesion instead of having implanted hardware. And we'll talk a little bit more about DBS and describing it. But the first point I really want to make is when we're talking about any of these surgical interventions, we're talking about a subset of patients with OCD. The patients who we would consider as candidates for surgical interventions have very severe treatment-resistant OCD. So, for example, for DBS, we do a very careful assessment, making sure that they have a high score in the Y box, they've had OCD for 5 years, and they've had multiple medication trials, as well as, importantly, an adequate trial of exposure and response prevention, or ERP.
Yeah,
maybe Dr. Tafreshi can describe a little bit more about the procedure of DBS.
Yeah, I think that's certainly an important disclaimer to have at the jump, though, that this is for a very specific population of those suffering from OCD. Is there kind of a standard definition of treatment refractory that, like, if someone's watching this, they can kind of think of?
No, but the one that we use for DBS, so the deep brain stimulation actually has a partial approval from the Food and Drug Administration, the FDA, under what's called the Humanitarian Device Exemption, or HDE. And in order to perform DBS for OCD, the institution and investigators have to obtain IRB approval from their institution. And there are specific requirements that you have to conform to. And that include, get specifics around the medications, multiple trials of SSRIs, also a combination of a serotonin reuptake inhibitor with an antipsychotic. And they had to be adequate trials of those medications. Severity has to be a 28 or more on the Y box, which brings us to like the severe extreme or extreme range. So these are patients who are, in some cases, incapacitated by their OCD, but at least severely impacted in terms of their ability to work or to pursue their studies.
Yeah. So this is for very severe patients who have tried a lot of things, and given the more frontline treatments, I suppose, a real go. I'll turn to Dr. Tafreshi now. Dr. Tafreshi, what are kind of the surgical interventions around, and what is DBS, I guess, from a mechanical perspective?
Sure. Yeah. No, I think I agree completely with Dr. Goodman. Everything you mentioned. So the lesional procedure that we're talking about, or in other words, basically a procedure where you, for lack of a better word, have to kill a piece of brain tissue in order to kind of remove it from the pathological disease process that's in the brain. Those are called cingulotomies typically. That is one of the places, the cingulum in the brain, where you can essentially burn either with a laser or radio waves. You can burn this piece of brain tissue, and that's thought to be contributing to part of the disease process, basically. Myself and perhaps others, I think Dr. Provenza and Goodman will talk about this too. We kind of can envision the OCD disease system as basically a vicious cycle, both from a behavioral and thought perspective, but also from the actual neurons. It kind of creates this loop that you have to somehow stop. Now, if you were to burn that piece of brain tissue that's part of this loop, you would potentially stop it, and that's kind of the theory behind this. There are a few targets that you can find in this loop to shock, or I guess to burn and essentially remove that tissue from this cycle. Cingulotomy is one of them. Subcaudate tractotomy. These are just terms of different places in the loop where you would kill the brain tissue intentionally. Of course, killing brain tissue sounds scary, and it is less ideal than not killing brain tissue in the case of deep brain stimulation. And we can get into this as well, but new research in this day and age has shown us kind of what this loop I'm talking about physically is in the brain. It basically, you can think of it as a highway with a bunch of different stops on it, and we can kind of pick one of these stops and intervene. Deep brain stimulation puts a permanent electrode in one of the stops on the road, and that essentially gives you access to the electrical activity of the brain. You can stimulate and you can add electrical activity. These days, which is the basis of my research, you can read and record that activity, so you get access in a way that you're not damaging or destroying the brain. It's reversible. That's why it's preferred if a patient can have deep brain stimulation. Again, this is a very case-by-case situation. The deep brain stimulation offers these advantages, and that's kind of why we tend to focus on that as the primary intervention, surgically speaking.
Okay. So the ablative surgery, just to kind of put it in very basic terms and buckets, I suppose, is you're going in there, you're going to the circuit that we associate with OCD and killing a part of it. DBS, you're not killing anything, you're more modulating it with electrical stimulation.
Exactly.
Okay. I guess this naturally leads to a question then. How do you know where you're stimulating? Like, how do you pick the targets?
Well, I guess years and years of research and scientists who have kind of given us that circuit understanding of the brain tells us some of the most effective areas. But I think if I were to fast forward, I guess the real answer is, these are all relatively innovative approaches in the grand scheme of things, and we're constantly trying to discover the best place to stimulate. The discovery of these targets came about, as with most, I guess, neurosurgical procedures, by some kind of accident that showed us that this brain region is involved in the OCD disease state. But I guess, how do we know? We understand the circuitry, and physically speaking, how do we know if we're in the right place? Of course, we use a lot of neuronavigation techniques to know exactly where we are in the brain, but I sense that's not exactly the how do you know that you're asking, but yeah.
Well, I mean, that's a helpful how do you know. I guess I'm also wondering, like, to what degree of certainty do we know the place to poke at? It sounds like a lot of it is kind of still in the works of trial and error. So I don't know if this is better for Dr. Provenza or Dr. Goodman, that question.
We should turn to Dr. Provenza.
So the question is, how do you know where to poke?
Yeah. So how do you know where to stimulate? And
Yeah,
with how much certainty?
So I think we're pretty certain about a couple different targets in the brain that improve OCD in general. Different groups of physicians kind of have different preferred targets based on their own experience. And a lot of these targets lead to similar positive outcomes. The target that we focus on at Baylor College of Medicine with Dr. Goodman and Dr. Sheth is kind of this region that when we turn stimulation on, we oftentimes see these kind of immediate acute responses in terms of mood and energy. So immediately when we stimulate at the right place, patients often have these, they say, I feel lighter, or I feel happier, I feel love in the room. And those acute effects eventually turn into OCD symptom improvement, but it takes time, usually weeks, sometimes months, maybe up to a year. So for us, we like to see those acute responses as kind of a positive indicator of improvement. But even in patients that we don't see those acute responses in, that doesn't necessarily mean that they won't eventually get better. We just think of that as kind of an indication that we're in the right spot and that we have engaged the right circuit.
And just to underscore that point, and this may come as a surprise to some of the audience, we actually do wake up the patient during the surgery, and I'm there not to perform any surgical interventions myself. I don't scrub for the surgery, but I'm there along with Dr. Provenza, who's doing some recordings, and what we do is to try to confirm that we're in the right spot by that behavioral response that Dr. Provenza just mentioned. So what Dr. Sheth and I are looking at, and sometimes we look very closely, we're looking for when we turn on the stimulation in the operating room, we're hoping the patient feels better. And what we often see is actually they begin to smile or sometimes express that they feel happy. And so we're looking for the smile, we're looking for the increased energy, and that helps confirm that we seem to be in the right spot. And by that, I mean that there may be other spots that are even better that we'll identify in the future. But in our own work, it has predictive value. So if we see that acute positive effect, what we often call a mirth response, where the person feels happier, they feel more energetic, they feel less anxiety, that predicts with high likelihood that their OCD is eventually going to improve.
Okay. John, I want to give you a chance to ask a question because I feel like this is where you normally have a question.
Yeah, it's really cool to hear you guys describe. So it sounds like it's not necessarily like here's the OCD circuit and we're going to intervene, at this place, and for everyone it's exactly the same and all of that. It sounds like it's more like we're going in and we're going to see if we get some sort of a positive response, and that predicts folks doing well. I mean, do we know? Yeah, go ahead, Nicole, you started to.
Yeah, so I can answer this question. So we at Baylor go in and target a specific region of the brain, the ventral capsule and ventral striatum. It's just that there are 4 places on the implanted lead that we can stimulate, 4 different contacts. And so the question then becomes, which contact is going to give us the best response? And sometimes—
Sorry, could you back up and explain, what do you mean by contacts? What does the lead look like?
Absolutely, yeah.
I'm having trouble picturing.
The lead looks like a very, very skinny spaghetti noodle. And at the end of that noodle, there are 4, cylindrical contacts, very, very small, that, one is at the bottom and then the next one is above it. They're just a couple of millimeters apart. Yeah. And there are 4.
And that's where the electrical stimulation comes from?
Exactly. That's where the stimulation comes from. We can also record from those contacts as well. And so we have 4 different places on that lead that are all very, very close together where we can stimulate. And we often see very, very different responses at each of those locations on the lead. Even though they're so close together, the brain circuitry in this region is very it responds very specifically depending on exactly where we stimulate. So one of the things that we do in the operating room is we test all these different contact configurations with different levels of stimulation to try to find the best one. So when we implant the lead, we know like pretty much the region that we're putting it in is going to give us the desired response. But we have this like fine-grained tuning that we can do within a few millimeters to find the optimal location in that spot.
So you put this lead in, you have 4 points on this spaghetti noodle where you can initiate electrical stimulation. And then you just see which one gives you the best mirth response, as Dr. Goodman said? Or
Exactly.
like, what are you looking for in the OR? Yeah. Okay.
Yeah.
So that's what I was gonna ask. Like, what are you looking for?
So we look for the smiling and laughter that Dr. Goodman talked about. We also, in some patients, it doesn't really manifest as smiling and laughing. It might be kind of a calming anti-anxiety feeling or even a rush of energy. We had one participant say they wanted to go skydiving when they had this feeling in the OR. And so, yeah, those are the types of things that we look for. And if we don't see it, we do have the ability to take the lead out and put it in a slightly different trajectory or angle so that we get to trial out, a very nearby but different piece of brain to stimulate. And we're usually successful in generating this response in our patients.
So when someone says, "I want to go skydiving," like, what does that mean to you? What's happening?
So I want to let Dr. Goodman respond.
Okay,
to
so
that.
that means that they're becoming energetic. So we should probably, it's a good time. There are side effects. And we could separate the surgical side.
I was going to ask you about those. Don't worry.
Well, I'll let the neurosurgeon talk about the surgical ones. But from a programming standpoint, and what I should really mention is my main role is to do the programming. And that starts about a week or 2 after the surgery. So after the brain's had a little time to heal, and then the patient will see me in the office, and I can communicate with the device. So what we didn't explain exactly is that these leads in the brain there's a wire that's tunneled under the skin and then connected to a device that's called a pulse generator. That's very much like a cardiac pacemaker. In fact, sometimes it's referred to as a brain pacemaker because of the similarities. And then I can, with a tablet in hand, so I have a tablet, and through a Bluetooth-like connection, I can communicate with the device and then make those adjustments in the stimulation. Dr. Provenza mentioned I can decide which contact is active. I can adjust the amplitude. I can adjust the pulse width. And so over the ensuing weeks to months, I can fine-tune the therapy. And here we get to the behavioral side effect. The main behavioral side effect in this target is the induction of hypomania. And I always explain this to patients before. It's like, there is one thing that you need, there's more than one thing, but one thing in particular you need to know about is I can make you too happy. And as you know, most patients with very severe OCD or depression say, "Oh, that sounds fine. That's great." No, it isn't. We can overshoot. And it can reach the point where you have a decreased need for sleep. You do impulsive things. Maybe skydiving is one of them, and you start to take risks. And as we know, most patients with OCDs are not big risk takers. So we kind of change that bias. So I do have to be very careful in the course of programming to not overshoot.
Huh. Are you seeing changes in like obsessional thinking? Do they still have the same thoughts, but they're not anxious about them? Like what are the specific? Yeah, like how do you know that it's working?
It's working.
So it's okay if I answer that, and then I don't want to.
I wanted to make a comment on the surgical,
please go ahead.
what's going on there, if that's okay. But that's definitely a very important question that I want to get into. I guess if I were to kind of conclude the how do we know conversation, I would say that we begin with many years of research that have brought us to a variety of targets that might work. And modern day researchers have, we are confident that the ventral capsule, ventral striatum is the target that we want to go for. So that's a brain region that's a certain size itself. It's relatively small. But what we do is on a per patient basis, we try to shave this down and make it as precise as possible with all the information that we have at our disposal. So what Dr. Provenza and Goodman were discussing, definitely. So when the patient's awake, the best objective and subjective response that we have is how the patient is feeling in the moment. But we have some data that we can use from the circuitry research that we have, where we can actually view this highway system in the brain physically. So we can see the circuitry of the OCD network on the patient's brain using MRI scans that we have from the patient prior to surgery. So not only can we map out exactly the target, we can map out the roadmap so that when we're moving this lead up and down, or the device that we use in surgery allows us not only in and out, but back and forth, like Dr. Provenza was alluding to, we can find exactly in that patient in the moment what is the biggest change that they're having. At MGH, what we also do is, in addition to the mirth response, in addition to the subjective reporting, we do a numerical scale of mood, anxiety, and obsessions. So we have the patient rate 1 to 10, how they're feeling in each of these categories. And we basically put all that in surgery while they're awake. And this is on the other side of the drape. So when we're placing the leads from the surgery side, our psychiatry team's on the other side taking these scales. And I guess, we have all this science and we have all this research, but at the end of the day, it's a very interesting feeling in the operating room when you've hit the target. And I think Dr. Goodman Provenza can kind of attest to this fact. We know these patients very well, particularly from the surgery and psychiatry perspective, where we've been following these patients for potentially years. And we can tell the moment where that burden of this thought is lifted off of them. And we can see this in the room, and it affects us as surgeons. The last case I did before, actually it was a few months ago, we kind of started tearing up in the operating room because we knew how much this patient had suffered from their OCD. And yes, they had a mirth response. Yes, they smiled, but we can tell in the way that they're speaking that we are in the right place here, basically. And we have all of this information preoperatively that brought us there.
Obviously phenomenal to hear. Before we kind of end this where to place the lead on the brain discussion and talk more about what Dr. Goodman was kind of alluding to, which is like the fine tuning after the fact. Dr. Provenza mentioned that there's different hospitals that target different places. So I was wondering, like, how do I reconcile that? Like you've all talked about the ventral striatum, I think, and the ventral capsule. Are there hospitals that would say, no, that's not the best target, and they would say we should do somewhere else?
So I would say, I guess in the case of like other things that we do deep brain stimulation for, like Parkinson's disease, for example, which is the biggest the biggest volume of surgeries we do for deep brain stimulation, it is somewhat less of a debate where we should be targeting right now. We have found other regions and we've implanted them at MGH, of course. However, I think the standard right now is ventral capsule, ventral striatum. In exceptional cases where either the patient's symptoms or circuitry or what have you, a variety of considerations, which we won't get into, might lead you to choose another target. I would say the standard is probably still ventral capsule, ventral striatum.
It certainly is in the U.S., but there are certainly places in Europe where they target an area of the subthalamic nucleus or STN. It's a little different from the Parkinson's one, but that also has shown promise. It doesn't seem to have as much of impact on depressive symptoms. But there were some good results out of Europe. Okay.
So I'm turning back to what Dr. Goodman was talking about in John's line of questioning. You have this patient in your office, Dr. Goodman. I guess you're fiddling with a tablet and you're changing the stimulation that's going on in those spaghetti noodles.
Don't say fiddle. We're not fiddling. Hopefully.
Sorry, I'm using a lot of euphemism. We're very scientifically fiddling with the electrical stimulation. What are kind of the indicators that we're looking for, follow up to see if this is really working?
So there's a two-part answer. So one, I'm still looking when I'm making the adjustments in the clinic, I'm still looking for changes in mood, energy, and anxiety. Interestingly, for the most part, I don't ask about OCD. not acutely. What I am interested in is how they did. So let's assume the visits are a week apart. We're going to do a Y box, right? And see how they're doing. So I'm going to ask them what changes have they experienced in their OCD, and that's the real answer. I mean, that's what I'm really looking for. So acutely, when I'm making the changes in the clinic, again, it's just those acute effects on mood, anxiety, and energy. But the real test is, or the Y box scores coming down. If the Y box scores are coming down, I may not be going in the right direction. But there is this lag time between effects on mood and effects on OCD. Some patients, it's early. Some patients, they say, going back to your question, Dr. Abramowitz, some patients will feel that they'll still have the same thoughts, but they're not as intense. They're not as loud, some patients say. They don't feel they need to respond necessarily as strongly with a ritual. So it starts to fade a little bit. But it's not all. It's rare that you see it just dissipate. I mean, it'll take time, and from patient to patient, it really varies on how long it takes for the OCD symptoms to catch up.
So is it that the stimulation is doing something to an OCD circuit, or is it a kind of general, we're improving mood, and then on down the road, oh yeah, I feel better, and so I'm not as anxious anymore. I'm not having, as much concern about obsessions anymore. Don't need to do these compulsions, or maybe we don't know.
That's the huge question.
Yeah.
I have thoughts about that, but I'll turn. Somebody else should have a chance.
I think it's an OCD circuit for sure, but I also think that the circuit is responsible for many different functions beyond, just obsessions and compulsions. One theory that we have been exploring scientifically is the theory that DBS makes patients less avoidant. We tend to think of OCD as a manifestation of avoidance in some patients, that OCD kind of lifts that avoidance and enables patients to engage in their OCD triggers, like kind of how they do in ERP, but in everyday life more effectively. And we think that these kind of real life exposures and the ability to approach the exposures improves over time after DBS, leading to a gradual improvement. So maybe the circuit that we're engaging is kind of allowing for that reduced avoidance, if that makes sense.
The other, also to underscore that point, one of the observations that the group in Amsterdam has had, and we've had in our studies, is again, all these patients have failed ERP, or in some cases couldn't tolerate it, and despite being in the hands of an expert therapist. But that once the DBS kicks in, and so we're about say about 6 months into the DBS, and we're seeing some improvement, we give them a booster session of ERP. And in our recent study, we haven't published the results yet. We found that, again, these are patients that failed ERP, and all of a sudden now they're really, they can engage in ERP again.
That's what I was going to ask. Yeah.
We see further improvement in their OCD. So it's actually the DBS augments the ERP.
It makes sense, right? That's what should be happening.
It does make sense, although I feel like I'm not fully sold on this idea that it's not just a general mood boost leading to downstream effects, rather than it being kind of a target on an OCD circuit per se. Is DBS used in other psychiatric disorders, and is the target the same if it is?
Well, I suppose for depression, this is one of the targets that is targeted. Yes. It's not the main one. I guess your question is very well founded in that there may not be a clear way to tell, but the reason, I guess the question is this not a placebo effect, but is it like a confounder or like a modulator? So if you're just happy, or if your mood's better, everything's kind of better. that's extremely difficult to answer in a disease that is heavily imbued with mood disturbance. It's almost like while it's a very important question, it may not even necessarily matter that much because you're targeting, like for example, we talk about the Y box, which is critical. We use the MADRS scale, the depression scale, just as much as we use the Y box equally. Every time we get the Y box scale, we get the MADRS scale as well, and we trend both of these things over time. So these are disease states that are integrated to each other. Of course, Dr. Goodman knows all about this. It's not necessarily as much my territory, but from a circuitry perspective, it's the same deal. I think the thing about OCD is everyone. There are so many people in kind of common language that say, "Oh, I'm so OCD about this. I'm so OCD about this. Oh, I have OCD," but of course they're not diagnosed. The idea is that all of us have this circuitry that we are in touch with, and we understand it, even if we don't have severe OCD. And it's just that circuitry gets louder and louder, and it causes these perhaps treatment refractory situations or disease states that people are in. But ultimately, it's not, we are kind of proactively affecting mood as a part of this disease state in general.
Mm-hmm.
So I can give you my take on it, Kyle.
Go for it.
Okay, so my thinking has been evolving on this, and my hypothesis hasn't been proven or disproven yet. But I if you remember when we're talking about the ventral capsule of interest, right, and we really haven't told you too much about what goes on in that area of the brain. It's a deep area of the brain, and it's involved in reward circuitry. So it's not surprising that when we stimulate, we get an effect of increased energy, and if we overshoot it, we get hypomania. We get people that are too reward seeking. In general, in the general case of OCD, even though symptoms may vary vastly from patient to patient, one of the common themes is that most patients are their behavior is dominated by harm avoidance. They're not reward seeking. Even compulsions, and when we always make us as OCD experts are always making this point, compulsions in themselves are not rewarding, they're not gratifying, they're a means to reducing anxiety or reducing the distress related to the obsessions. So patients with OCD are not motivated by reward, they're trying to avoid some consequence. So what I think happens when we change the bias, we change circuit bias, so that we're increasing activity of reward circuitry, we're changing that relationship between seeking reward and avoiding harm. So, and I think that's very critical to OCD. So if you have a patient that's been living where OCD has been ruling their life, and they're doing everything to avoid harm or some other adverse consequence, and all of a sudden now you turn up the gain of reward circuitry, that competes with the OCD. And over time, they begin to learn, gee, that's more fun. and again, it takes time to unlearn or extinguish some of the OCD behaviors, realizing as the more reward or approach behaviors begin to displace the ritualistic behaviors.
So, okay, I just want to make sure I understand it and the audience understands it. In OCD, the argument is that a compulsion isn't something that's like, it's not a reward chasing behavior. It's essentially to get rid of a scary thing, which I would imagine is reward in and of itself in a way, right?
It's like saying, when your bladder's full and you empty your bladder, I guess that's good, but that's tension.
It's not quite the same thing as getting.
It's not quite the same. It's a tension reduction.
Well, it's negative. I mean, it's you're talking about the difference between positive reinforcement and negative reinforcement. Compulsions are maintained by negative reinforcement, right? So that you're in a distressed state and you do the compulsion, you feel better, right? So, I mean, in a way it's a reward, but really what you're doing is you're removing some sort of negative stimulus, right? And as opposed to, what we think of as being rewarding, which is where we acquire some sort of appetitive stimulus. And I could see where brain circuits are different for positive and negative reinforcement.
Exactly. Like,
And with DB, you go.
I was going to say, like, successfully running away from a bear is like a different kind of feeling than like eating a slice of pizza, for example.
Right. It's more like, ooh, I escaped that one.
Yeah.
Yeah. Right.
Versus
And
like,
that's what
oh,
folks
that
are
was a lot of
looking
cheese.
for.
And then when you go in with this spaghetti noodle, start stimulating the ventral capsule ventral striatum more than you typically would, is the argument that that makes the reward system a little more sensitive in folks with OCD? So they then are like, oh, I also like doing life things rather than just running from fear. And that leads them to be a little bit more,
Exactly.
or I guess less. Okay.
This is our
Okay,
theory.
cool.
We are
Yeah.
working on some research now that would kind of provide evidence for this theory. But this is kind of anecdotally what we see in many of our patients, and many of our patients find this kind of framework very relatable. So yeah, you said when you were reading my bio, my background is in biomedical engineering, and so my goal is to try to figure out, what are these behavioral changes that are happening, how can we quantify them, and then how can we relate it to the brain activity that we're recording on board these devices.
So I'm fascinated by that. Can you tell us more about the research that you're doing to try to figure that all out?
Yeah, so luckily the newer devices that are available for DBS can record brain activity while we're stimulating, and these recordings happen passively and continuously on board the device. We just have to meet the patient and download the recordings that save on board the device every 30 or 60 days, depending on whether the device is rechargeable or not. And we concurrently have patients where devices like Apple Watches or Oura rings, I'm wearing an Oura ring right now, that track activity level, sleep patterns, physiology like heart rate, and we can relate, these behavioral changes. Like a lot of patients that get DBS for OCD, once they get better, they become much more active than they were before. They're leaving the house a lot more. They're, more active socially. They might work out more. And we can track all of these changes and then relate them to changes in the brain activity that we're also recording to try to figure out what, what OCD symptoms look like and what an unburdened, neural activity pattern looks like.
Mm-hmm. And have you seen differences, or is it still too preliminary?
Yeah, no. So we are really proud of some work that we put out at Baylor last summer in Nature Medicine. We, in a group of 12 patients who had this device, we identified this neural activity pattern that it was kind of very predictable and not variable prior to DBS. But in patients that responded to DBS, the pattern became very, very unpredictable and highly variable throughout the day. So we kind of think of this as, breaking out of kind of the rituals of OCD after DBS, after patients respond. There's kind of an expanded repertoire of behaviors. There's not a limited number of responses that someone might have to any given stimulus. It's more variable, and that's what the neural activity is kind of showing us. And so I've seen in the chat a lot of people are interested in adaptive deep brain stimulation, and I think we're kind of on the path to figuring out, what a healthy brain looks like, what an OCD brain looks like, and maybe even understanding some of these side effects that happen when we overstimulate. And so eventually we might get to the point where we can enable data-driven intervention, where we can automatically adjust the stimulation parameters up or down based on neural activity on a specific day, for example.
Mm-hmm. Yeah, that's really fascinating. And it's an interesting hypothesis that I guess this pattern becomes a little less hard to track in folks where their OCD is turned down a little bit, and then they have kind of this wider range of emotions and behaviors they can exhibit in the world because they're not being hampered by this OCD anymore. I'm curious. We don't have too much time, and someone mentioned in the chat that this definitely deserves a second roundtable, and I would agree because there's a lot of questions. Dr. Goodman, is the stimulation continuous, or
Yes.
is it in bursts? Okay.
It is continuous. The other thing too is we do give the patient what we call a patient programmer, and it doesn't allow them to make as many changes as I can. So I set the kind of the limits, make sure that they're safe limits, and especially early on in therapy, patients are more activated, they feel more energy, and that may actually interfere with sleep, either falling asleep or staying asleep. So one of the reasons we give them the patient programmer, it allows them to turn it down a little bit at night, fall asleep, and then in the morning they turn it up and they get a little bit of a jolt. It's like having your morning coffee. Over time, most patients don't seem to have the need to turn it down at night, but one of the things, since again, I'm going back to the fact that I can glean some information from that clinic setting, but really the most important information is what happens in between visits. And sometimes I'm not sure which way to go. So I may set up like 2 different groups, and I'll have the patient say, why don't you stay on this group of settings for a week, and then switch to this other group, go for group A for 1 week, group B for 1 week, and then get back to me and tell me which one you think was better. And that will help guide me on what to do in the next programming session. And they can also, again, they can make adjustments within the safe range of the amount of amplitude.
Mm-hmm. And experientially, how long does it take to tune this sort of machinery?
Again,
like to find the range.
It varies from patient to patient. You know, some I get there within a few weeks, and others it's months, and may even take a year. You know, that would be on the long end.
Okay. And I mean, I'm shocked we haven't asked this question yet. What does the data show about the effectiveness of this procedure?
So we published, our group published a meta-analysis of all the published literature on DBS, not just this target, but other targets. And the response rate came out to 66%. So 2/3 of patients. And that was based upon a Y-box score of a 35% decrease or more. It still leaves room for improvement. And in our own anecdotal experience at Baylor, we're up to about 80%, but still we're not at 100%.
Mm-hmm. Oh, for someone who's got 28 on the Y-box, that's pretty good.
Yeah, it's a meaningful drop. Okay. So that's how how does that compare, I guess, to SSRIs with antipsychotics? Like, relatively speaking, is 66% like wowza, or is that not?
That's pretty good. It's pretty good.
Well, all of the patients that get DBS have already failed multiple trials of SSRIs and an expert ERP, and as Dr. Goodman mentioned, an augmentation of an antipsychotic. So, these are the patients that have failed everything else that's out there. So the fact that 2/3 get better after DBS is pretty amazing. But like Dr. Goodman was saying, success is defined as a 35% reduction, which isn't the same as, remission. So we're hoping that the research we're doing is going to help improve our ability to bring patients to remission and achieve a 100% success rate.
Have there been studies that look at the percent that achieve a 50% reduction, remission percent reduction?
I can't remember from the meta-analysis. We probably looked at that. But often this question comes up about the Y-box. 35% doesn't sound like a lot, but I don't want to get too technical about it, but the Y-box is nonlinear with respect to time. So even though it's a 35% reduction, that may mean that a difference between having OCD 8 hours a day to 3 hours a day. So it can be the difference between not being able to work to being able to work.
Yeah. So 35% is nothing to scoff at.
No.
And Dr. Goodman, correct me if I'm wrong, but some patients that don't achieve that 35% reduction actually still, note that they do experience significant benefit after getting DBS.
Mostly in the area of mood. Yeah. So yeah. So one of the things one of the nice things about DBS is that it is reversible. We haven't talked about that, but if it turns out like, it's a year, 18 months, and it hasn't worked, what we'll often do is, especially if the patient feels that it hasn't made much of a difference, but maybe I think it's made a difference, we can turn off the DBS, and then we can make a decision about whether the system should be explanted, removed, or not.
Mm-hmm. Okay. I didn't know that it was completely reversible. Speaking of things that are irreversible, Dr. Tafreshi, I was wondering, have there been large efficacy studies on the ablative procedure that you mentioned way at the beginning of the show?
Yeah, and I think some of the more, I guess, robust data from that actually came from the Baylor group as well. It's a little bit less, somewhere around 50 or so, or a little bit under 50. But again, those are tend to be, at least these days, patients who may not be able to undergo DBS, which might be saying something about the severity of their disease or prior procedures or what have you, or other conditions that might complicate a surgical approach for that. And the other thing I would kind of add to this is again, I keep bringing this up because there's not a whole lot of follow through with this, but sometimes in certain patient populations, the MADRS, the depression score, which is heavily comorbid with OCD, actually goes down in greater percentage than the Y-box might. So if you have a 70-80% response rate, what you guys are quoting as well at MGH, similar to 80 or more, you might have close to 100% reduction in MADRS in depression. So that's also something worth noting that you might not. It's a very excellent objective way to define success, the Y-box cutoff, but there's more to it, like Dr. Provenza suggested.
Yeah, and Dr. Goodman mentioned some of the psychiatric side effects and the induction of hypomania. Now that I got you talking, Dr. Tafreshi, what are some surgical side effects that a patient could expect or might be wary of?
Yeah, so I guess the first thing to think about is whether so like we've mentioned, the surgery is done awake. That does entail having to kind of sit in the operating room for 2 to 3 hours when this procedure is actually done. Of course, we take every precaution possible to make sure that you're as comfortable as you can be. We have anesthesia, we have medications that we can give for pain and discomfort. The patients that we've operated on, and there has been no instance where they were unable to tolerate being in the operating room and on the table for the duration of the surgery. However, also to keep in mind, any brain surgery we ever do, there's risks of things like infection, things like bleeding. However, again, for whatever it is, I don't have the numbers on everything, but none of the patients that we operated on over the time that I've been at MGH have had that issue. It's a relatively, as far as neurosurgical procedures go, relatively lower risk. But I would also add that it's probably one of the most carefully done surgeries in the neurosurgery repertoire, I suppose. There are a lot of devices we have to move extremely precisely and extremely in a very measured way. So because of that, the complication profile is relatively low. In addition to, of course, anytime you have an implanted device, there's the risk of infection. This is just thinking of Parkinson's disease data, but again, haven't really seen that in our OCD cases. But again, things to keep in mind, but overall, very, very low risk as far as my experience goes for this.
Okay. That's good to know. And I guess kind of following up on that, I'm someone with OCD. Back when I was struggling the most, when I was in 7th grade, my parents looked into DBS quite a bit. And back then it was a little bit more, I suppose it's still experimental, but a little less was known about it. I kind of want to hear from each of you. How should someone like myself who lives with OCD, how should we be thinking about this technology? I mean, it sounds promising. It sounds nifty. But I also know a lot of folks in the community who have like serious reservations about it. So like, where do you all feel this technology stands, and how should someone with OCD be thinking about its application?
And I guess, you know what, that's a great question, just to kind of add to that. You know, right, we live in an age now where it's like, yeah, I can go, you know, get this operation, have this thing, and then I don't have to do exposure therapy, because exposure therapy sucks, right? You got to face your fears. So kind of to that same end, yeah. What would you say to someone?
No, they have to have had ERP. We wouldn't take anybody unless they've had.
But
ERP.
why? I mean, why? If this is like so effective?
So
No, I wouldn't. It's still brain surgery.
Right? I mean, have it.
Sure. Well, I think it's so effective because the patients are doing so many other things in addition to it. If this was the only thing that was going on, it wouldn't make sense. You know, we have to have everyone on board. You know, it can't just be a surgical thing.
On the other hand, some of the patients that we treat are not on medications anymore.
Yeah.
I think one way that I like to think about it is DBS for OCD kind of allows you to kick the ball back into the field. It puts it back into play so that other things like ERP might be more beneficial than they could have been before in this severely treatment resistant population. The way that one of our patients puts it is that DBS makes the work. You can't expect to not have to, you know, keep going on your exposures, or, you know, you can't expect for it to be an immediate, like, snap your fingers, this is a cure. But it allows the work that you're putting in to actually pay off in many cases. So I think in that way it offers hope for a lot of people.
And I think that's important for folks to hear, because I have had people say to me, you know, before they've really done, you know, maybe they've tried ERP, but they really didn't try it. They were, you know, or maybe someone was kind of like forcing them, like it's a young adult and the parents were like, you know, you have to get treatment, and they really don't want to do ERP. And they're like, why can't I just have the surgery? No one will take me for the surgery because, you know, I don't want to do this ERP. And it's important for people to hear exactly what you're saying.
Mm-hmm. Dr. Goodman and Dr. Fresh, do you have kind of a similar framework with which to think about its application?
Yes, of course. I mean, I think you know, for the right patient, I think this can be a life changer. You know, the patients that undergo this procedure, again, like, let's just say the number is 2/3 see a significant relief. Those would be patients who otherwise would be debilitated, or in many cases their lives at risk because of the severity of their OCD. So it's, you know, I think it's an incredible technology and incredible surgery that, you know, we need to expand access to, and we need to make sure that the patients who need it, you know, get the ability to be plugged into a group of psychiatrists, behavioral professionals, and neurosurgeons who can think about this. I think that, for better or worse, it's not something that at its current stage is for people who have mild OCD. So if that's something that you have, or even moderate OCD, where it can be managed in other ways to become either tolerable or allow you not to be debilitated, as with any neurosurgical procedure, that's how it should start. But this is all multimodal. This is all within the context of a multidisciplinary team and decision. And your disease state may evolve. Some people, it gets worse. For some people, it goes away. But I think it's important that everyone understands that this is an option, and that as far as neurosurgery is concerned, it's not nearly as scary as it might seem. The approach is minimally invasive, as minimally invasive as possible. It's really a couple of small, or one skin incision, and everything else is basically under your skin. And these devices these days are very small and thin, and you don't necessarily feel them nearly as much as you would in the old days when these were bigger. So I would say that I think they're like you mentioned, it sounds scary, but I think you know, any of the patients with severe OCD can tell you OCD is a lot more scary. And if you don't have access to this treatment, or if the people around you are too afraid to maybe tell you about it, you might miss out on it. And that's something that I think all of us on this panel would want to avoid. So I think there is a little bit of a stigma busting that needs to be done about it. And I think more folks should definitely be evaluated for it, even if that doesn't mean that everyone's now getting DBS.
And John, I know you have a meeting at 1, so you can feel free to leave. But Dr. Goodman, I want to give you a shot to wrap it up if you have kind of closing thoughts.
Well, I agree with what was just said about the value of DBS as an option. Access to care is an impediment, and I mean that in several ways. There aren't that many groups around the country that really are in a position. We really, at Baylor and other places that do this, believe in a team approach. So you really want to make sure that you have an experienced DBS neurosurgeon, a psychiatrist who understands OCD, and a psychologist who understands OCD. And we have to have that at Baylor and other places do as well. The other issue with access is it's an expensive procedure. And a lot of insurance, even if you have insurance coverage, they may deny it. So that it's very commonplace for there to be a long, drawn-out battle with the insurance company to get coverage. And we've written about that. We've written publications about problems with access to care, and made the analogy with Parkinson's disease. We haven't talked much about that, but I mean, maybe Dr. Tefreschi, you can mention too that, you know, how DBS is mostly used in movement disorders, particularly Parkinson's disease. And I don't know, is access to care the same? Do you have the same problem with getting a patient approved for Parkinson's disease as you do for OCD?
Absolutely not. No, it's much more streamlined, much easier. You can even think of, I think it was dystonia that was approved for under the humanitarian device exemption, which is the same deal as OCD. It's FDA approved under a certain provision, approved around the same time. Dystonia is always covered. That's not an issue. I think there's an element of psychosurgery stigma, or this history of psychiatric neurosurgery, and the way that the public thinks about it, and how it's depicted in media and movies. I think that there's something to be said about how that affects insurance practices, and you know, that's something that we should overcome. Again, not nearly as difficult for other disorders.
That's a shame.
Yeah. No, the kind of stigma and the troubles getting this paid for was a whole another line of questioning we could have gone down. I want to be respectful of everyone's time. This was a super interesting conversation. I think it's important that we kind of ended on that note too, as Nicole Provenza said, which is like, you know, this is maybe not a cure-all, but it's something that puts the ball in the field of play to then go do ERP and see those kind of life changes. But again, it's for a very particular group of patients, as Dr. Goodman started with, and it's currently for those folks who are really, really struggling. Just kind of a brief announcement: the 30th annual conference is coming up. It's going to be July 11th to the 13th in Chicago. I'll be there if you want to say hi to me. Not that that's like a big get, but yeah, I'd love to see you there.
Short, Kyle.
Stop it. Yeah, thanks to you all for joining, and we'll see you next month.
This was a lot of fun. Great to learn about what you all are doing.
Thank you so much.
Thanks a lot.